start without any delay. I am Dr. Shukla, Chairman, and Dr. Adarsh Kumar Sharma is with me here. We have co-chairman Pushpa Sahu, convener Dr. Rajkumar Sharma. He is not here. I know because, and Reshma Ravikant Shah. Any of you are here? Yeah, Anuradha Chandra is also one of the. Anyway, because we already 5 minutes late, we'll start this session. And and I'm just joking. So we start with the first paper, Dr. Vibha Singh, and myopia management, does atropine work? We already had this in the morning session on the symposium on myopia, but it's good. We'll keep on repeating. Please stick to the time. 7 minutes.
Thank you very much, AIS and Uttarakhand Society, to giving me this opportunity. Today we are going to discuss role of atropine in control of myopia progression. So there is no conflict of interest to declare, and there is no financial support from any source at the current presentation. Just in brief, we can just start from a picture. We can see there is lots of difference between the activity of previous child and today's child. Children are going to spend more time with the digital devices. Myopia is an under-acknowledged epidemic which has already affected nearly 30% of the world population in 2020. It may causes increased risk of cataract, glaucoma, and various posterior segment complications such as a myopic maculopathy, retinal degeneration, posterior staphyloma, retinal detachment, choroidal neovascularization, and so on. So there are, needless to say, various agents are there to control the myopia. Among atropine is only medication found to be consistently effective. 5-year results from the ATOM-2 study supported application of 0.01% atropine as a safest and most effective dose to restrict the myopia. There are many measures which are used to control the progression of myopia. It includes progressive addition glasses or executive bifocal spectacle lenses, peripheral defocusing lenses, contact lens, orthokeratology, multifocal soft contact lenses, outdoor activities, and pharmacological agent. It is so the parents of the children are in confusion what measure they will use to delay the progression of the myopia. These are some pros and cons of all the things we have. Myopia control glasses, there is no risk of infection, but children have to put all the time to have a effective control over the refractive error. Possibility of injuries from the damaged spectacles are there. In myopia soft contact lenses, this is more convenient during sports, which was lacking in a spectacle. In ortho case, there is no visual correction is needed during the day, and there is low risk of the infection. In atropine, parents able to monitor is to instill the eye drop, and there is no systemic side effect which is very severe to the children. These are some commercially available myopia control lenses, contact lenses, and drops. So we just come on the topic. History of the optical and surgical correction of myopia only concern improvement in the visual acuity, but these measures have nothing to do with the control of myopia progression. The how atropine work to delay the progression of myopia. According to theory 1, it may affect the myopia progression by inhibiting the accommodation. By the theory 2, it is believed that it is affecting the neurotransmitter dopamine release. It inhibits the stretching of the sclera. Or in theory 3, it is a non-muscarinic and direct influence of the atropine on the scleral fibroblasts could also contribute to the effect. There are lots of papers to support the topic. Now we are just confused about the dosing. In American Academy of Ophthalmology recommend the use of 0.01% atropine for myopia control. At present, 0.01% atropine is the most popular measure to control myopia. There are many studies. The strongest evidence initially from 1% atropine was there in ATOM-1 study, but in a but in a graphical representation, we can see there is a greater rebound with a higher concentration. So there is another study, ATOM2, in which we just study 0.5%, 0.1%, and 0.01% concentration of atropine, which randomly allocated in ratio of 2:1. Initially, no placebo was allocated, as 0.01% of atropine was considered to be used as a control group. Therefore, low concentration of atropine of myopia progression studies was conducted, which was double-blinded and randomized placebo-controlled trial to evaluate the safety and efficacy of low-dose control of atropine. This is a treatment protocol. If any patient comes, we just start with the 0.01% atropine and follow up after 6 months. If the refraction is stable up to 0.5% diopter per year, then we just continue or up to 2 years with a follow-up, regular follow-up. It is more progression is more than 0.05%, 0.5 diopter, then we can continue atropine with more outdoor activities, or we can increase the concentration of the atropine, or other measure we can use. Duration of the treatment we just discussed. There are non-responders also. So for the non-responder, alternative studies, strategies can be given. Safety of atropine. Topical atropine is currently the only treatment used for the slowing myopia progression. There is an emerging treatment also, in which there is a light used for slow the myopia progression, in which red blue light stimulation with 450 nanometers so selectively directed to the optic nerve head. It is intended to stimulate the photosensitive retinal ganglion cell at the location to increase the production of dopamine at the inner plexiform layer. And there is also documentation from the red light also, but it is all in the research. There is always a research graph. We are in the search of drop, which is one size fit for all. There should not be a rebound phenomena following atropine sedation, should be further investigated. To conclude my presentation, the myopia control become mainstream clinical practice for us eye care practitioner. Our goal must not be to just limit it for developing or slowing down the measure, but to discover a method to prevent the development of myopia. The take-home message: 0.01% treatment for the myopia control is a favorable risk-benefit ratio. Any subject who is progression more than 0.5% per year or more may be offered. With the myopia control, lower cutoff may be justified in the children with strong family history of the myopia progression, especially with the early onset. These are the references. Thank you. I just want to add, atropine should not be just stop immediately after completion of the 2 years. It should be tapered. There are 2-3 school of thought. It may be you can completely stop, and patient should be in follow-up. There is a dose manner or there is a frequency manner. You can reduce the dose 0.05% to 0.01%, or you can decrease the frequency either 4 times, 3 times, or atropine should be used if there is a less outdoor activity or patient is having a more near work. So thank you so much for patient listening.
Thank you very much. We'll have questions at the end of this session. Actually, all are speakers only. There is no audience. So, Now next we have Dr. Anupam Singh from Rishikesh, AIIMS Rishikesh. We can ask questions, with one another only later on,
Good afternoon, everyone. I will be talking about fine motor skills and amblyopia, which is less explored entity in amblyopic children. As we all know, amblyops have poor stereopsis, and that's why they can have difficulty in doing tasks which rely upon a stereoscopic vision. And this functional disadvantage of amblyopia has not been fully explored in childhood population, and there is scanty literature which has compared the type and severity of amblyopia with fine motor skills in children and adolescents. So we have done a study aiming to study the impact of amblyopia on fine motor skills in children and adolescents aged between 4 to 18 years. The primary objective was to compare the fine motor skills in children and adolescents with amblyopia aged between 4 to 18 years with age-matched controls. And the primary measure was Bender Visual Motor Gestural Test. And the secondary objective was to study any possible association of severity of amblyopia and different etiology of amblyopia with the degree of fine motor skill. The study design was hospital-based prospective cross-section study. The duration was April 2022 to 2023, and the sample size was 82, including the cases and controls. And the study population was taken from the patients visiting ophthalmic OPD and pediatric OPD of AIIMS Rishikesh. The cases and controls were recruited according to the inclusion and exclusion criteria, and those willing to provide written informed consent, and age range was 4 to 18 years, and only orthophoric patients were taken, and with having a primary position alignment within 8 prism diopter horizontal and 4 prism diopter vertical. The exclusion criteria was any existing pre-existing vertical or horizontal misalignment, or any history of previous ophthalmic surgery other than strabismus, any retina and macular disease or ocular trauma, any neurological disease or intellectual disability which can compromise the fine motor skill. After taking consent, the all basic workup was done, and the fine motor skills were assessed by 4 measures: Bender Visual Motor Gestural Test, Jepson-Taylor Hand Function Test, and Ray-Ostrich Complex Figure Test, and Developmental Coordination Disorder Questionnaire, which was subjected to the parents of the patients. And all these tests were performed by a trained resident in supervision of a pediatric neurologist. In Bender Visual Motor Gestural Test, it consists of 9 index cards, and patient was asked to copy this, and the scoring was done according to accuracy and organization of the reproduction, and scoring was given between 1 to 13, and higher score indicated poor performance. Then Ray-Ostrich Complex Figure Test was done, and patient was asked to copy this replica, which is Ray complex figure, and again scoring was done, and the score was given between 0 to 36, and in this lower score indicated poor performance. In next test, Jepson-Taylor Hand Function Test, the patient was asked to do 7 things: writing, turning over pages, picking up small objects, fine objects, large objects, and so many things with both hands, right and left hand, and the scoring was done. The time taken to accomplish the task was recorded as the score. And the last, Developmental Coordination Disorder Questionnaire, this was subjected to the parents, and parents were asked about the different coordination problems, and it consisted of 15 items, which include control during movement, fine motor and handwriting, and general coordination. So primary outcome measure were assessed. That was visual motor coordination. That was assessed by Bender Visual Motor Test. Then secondary outcome, upper limb dexterity, was assessed by Jepson-Taylor Hand Function Test, and visual spatial constructional ability was assessed by the Complex Figure Test, and visual motor coordination was assessed by the questionnaire. The mean age was 9 in control cases and 8.44 in controls, and the male and female ratio was similar in both cases and controls. The most common type of amblyopia in our study population was meridional, followed by anisometropic, and strabismic and emmetropic. And the most common population, up to 74.55 patients, were moderate amblyopes. And we saw the type of refractive error. The astigmatism was the most common type of refractive error, followed by hypermetropia in cases, and hypermetropia was the most common refractive error in controls. And we also assessed the baseline and that body mass index, which was not related to the severity of amblyopia. And the primary outcome, there was a statistically significant difference between the primary outcome measure that was done in Bender Gestural Test. Then all secondary outcomes measures had statistically significant difference between cases and controls. Also on subgroup analysis, there was only strabismic amblyopia has significantly, on subgroup analysis there was no major difference within the other types of amblyopia, but only strabismic amblyopes have significantly reduced fine motor skills. So the mean standard deviation of the fine motor test in amblyopic group was significantly higher than controls, and proportion of amblyopes, only 40 patients of cases had binocular single vision, and rest of the patients they didn't have. Poor performance by amyloids and controls with reduced and nil stereopsis was observed, that is very obvious, but only strabismic amblyopia is found to have most abnormal fine motor skills that we have already said. So to conclude, amblyopia adversely affects the fine motor skills of children and adolescents, and this entity is still to be explored, especially in Indian populations. There is no Indian study till date. And to reduce stereo acuity may have to related to this. This is obvious, but especially we are emphasizing the strabismic part of strabismic amblyopia has poor prognosis. So this is this highlights the importance of early correction of strabismus. The patient's strabismus surgery should not be delayed till most of the clinicians say do it in adulthood, 18 years का हो जाएगा तब करेंगे, and patient land up with severe amblyopia, and these problems can hamper their other job selections and all. Thank you.
Thank you, Dr. Anupam Singh. Thank you very much. We'll have questions at the end of this session, so whatever you want to ask, you can just write it down and then you can have it at the end of the session. Now we have Dr. Soma Ganesh from Delhi, and she will be speaking on approach to pediatric strabismus vertical squint analysis. Little complicated, so keep your eyes open.
No, I'm going to do a little bit basic only. I'm sorry if there are only speakers. So I would first thank the scientific committee for inviting me here, and respected chairperson and co-chairperson, sir. So I would be speaking on vertical squint analysis and management. So this is a child who has right hypertropia. Now how do you distinguish it? See, the other eye, one eye is coming down and the other eye is going up. So this is a true hypertropia, okay? So now you see the other eye is coming up. So this is how, in the next, this is a child who has, if you see here in this video now, this eye is coming down. The left eye is coming down. We are doing it with the Spielman's occluder. The right eye is also coming down. So this is DVD. Okay? So this is how you differentiate between a true hypertropia and an alternating hypertropia, that is a dissociated vertical deviation. So the simple test helps you to distinguish. So, and this, the child, the other, this hypertropia where you can have is when there is a, you will get a nystagmus. See the nystagmus which is there? So this cyclovertical nystagmus is normally seen in DVD, dissociated vertical deviation. So there is a latent hypertropia, latent DVD here. So that's how we differentiate. And the surgical, put the management, but the surgery for a simple DVD is a superior rectus recession, depending on whether it is unilateral or bilateral. So you will do superior rectus recession for a mild, moderate or a severe DVD. So you can do up to 10 millimeter of recession of superior rectus. And if it still doesn't work, you can still do a Farden. So now you can have an incomitant DVD when there's associated inferior oblique overaction also. So here you have, there is an inferior incomitant DVD, there is a inferior oblique overaction and a DVD. So for this, the surgery is not only doing, you have to do a inferior oblique anterior transposition. So basically you want to take care of the inferior oblique overaction also, and you want to take care of the DVD also. So now how will you measure it? So when the eye is coming down, so the first you will get that there is hypertropia. When you're measuring, first the eye will come down, the other eye is going up, and then you keep on measuring, and then you find that one stage it is neutral, but still the eye is coming down, and then you know that there is an hypertropia, and there's an inferior oblique overaction causing the hypertropia, and there's also a DVD. So we can measure like that, and that's how you will plan a surgery for an inferior oblique anterior transposition when you have both of them together. So this is how you will investigate and see. So this is where you place it just at the level of the inferior rectus. So this causes it causes a depressive effect, and that is how you will treat a inferior oblique overaction with a dissociated vertical deviation. And to prevent an anti-elevation, you will put both the bites together and you cause a hump like this. So this will prevent the anti-elevation. And you place it at 0 station. If you place it at 1 station, then you can get a overaction, or you will get an anti-elevation syndrome. So a true hypertropia, which cases we'll get in a congenital superior oblique palsy. If you have a superior oblique palsy, normally there will be a compensatory head posture. Then you can have facial asymmetry like this, like a hypoplasia in one side. And then you will have to do what the test is. You have to do a Parkes 3-step test. So whenever you have an hypertropia, you need to do a Parkes 3-step test. That is, you do first in the primary gaze, and then you do it in the gazes, and then you do it in the tilts. And then with these, I'm not going into the details of this because just 7 minutes. So, but Parkes 3-step test, you can come to the diagnosis of whether it's a superior oblique palsy or whether it is a superior rectus paresis. So if you have a right hypertropia increasing on dextroversion or on levoversion, increasing on levoversion and tilt to the same side, then we know it's a right superior oblique palsy. So if you have a right hypertropia increasing on right gaze, increasing on right tilt, then you have a left IO. So you just need to know these few things fast in your clinic to understand what the pathology is. So always in a superior oblique palsy, the tilt will present with the opposite tilt. In a child presenting with the inferior oblique palsy will come tilt to the same side of your palsy. So these are few tips for your clinic so that the vertical squint don't get hassled by it, but it's not so complicated also, it's not so easy also, but you don't have to get this. Hess chart is important. So in this case, you can see there's this Hess chart where showing you a right superior oblique palsy. And you can do a diplopia charting where you will see also. Now if this is a diplopia charting, so you have the outer image is the eye affected. So here you get the green. So we have put the red in the right eye and the left, and that's the green which is affected. So this is the algorithm for the superior oblique palsy, which is there in Rosenbaum. So if there is the important thing for the investigation is a forced traction test, and forced traction test tells you whether it is very lax. If it is very lax, then you need to do what is called as a tuck. Always think bilateral if you have alternating hypertropia and if there is a V ESO in down gaze. Okay, so that's why you need to measure in up gaze and down gaze whenever you're measuring, if you're seeing if there is alternating hypertropia. So you have a V ESO in down gaze, which will tell you that this could be a bilateral superior oblique palsy. Now you have a child with eye not going up, there's a chin up, limitation elevation, left hypotropia. So what are the two diagnoses you can have? Either it's a Brown's or it's a IO palsy. So now to Brown's we know that all these things are present. So how do you differentiate? Mainly we'll have a FDT is the test for differentiating between a Brown's and an IO paresis. And in a Brown's we'll have a V pattern in up gaze and hypotropia. So now this child presented with a hypotropia, everywhere it was written as Brown's, but there was an A pattern. So it is important for us to check all gazes. Now in an A pattern does not occur in Brown's, so you are thinking of something else. So you do a IFDT on table, and then you find that in FDT that it's a tight tendon telling you. So in this case it was not a tight tendon, but if it is a Brown's it will be a tight tendon. So the surgical procedure for if there is such a procedure for superior oblique Brown's, then you can either do a chicken suture or you can do superior oblique tenotomy or a tenectomy. And for A pattern with an IO paresis, you can also do, if you have a torsion, yes, you have to do a superior oblique tenectomy. If you don't have torsion, then you do a chicken suture for the A pattern. Okay. So I'm just telling you the clinical, that was my topic. So this child, we did a superior oblique tenectomy. And a right superior, because there was also a DVD, I did a right superior rectus recess with so that because it's an A pattern, superior rectus is an adductor and up gaze, so when you do a recession, you will get the A pattern also corrected along with your DVD correction. Last case, where this is again hypotropia, 30 hypotropia with an XT around 20 prisms. There's ptosis, true ptosis, and the eye does not go up. What is it? It's a double elevator palsy. Okay. So you also have to rule out, put this in the other eye and see whether it's a true ptosis or a pseudotosis. So here it is a true ptosis, and then what the plan is, basically you do an FDT. So the important investigation everywhere where you're doing is an FDT to rule out whether it, in a vertical squint, to rule out whether it is restrictive or paralytic. So if you have a restrictive, then you do an inferior rectus recession. Now if you don't, it's not restrictive, and you find that there is the superior rectus is paresis, then you will shift both the muscles, horizontal muscles to superior rectus for the paralyzed muscle. So that's called as a NAPS procedure. So all these cases, you have to know whether it's restrictive or paralytic. So FDT seems to be the investigation of choice. So to summarize, we need to check for the abnormal head posture, facial asymmetry, the deviation, Parkes 3 step is important. Ocular movements are important. Do bilateral for vertical squints. Sensory evaluation, Hess charting, diplopia charting, and evaluation of torsion. Thank you. What I could cover in 7 minutes.
You see, it's really complicated. The only complicated topic in strabismus is the vertical palsies. So she has done very good work, and in a very short time she has summarized. Naturally, she can't show many things, but these vertical palsies have to be, actually done only when you are a strabismologist or you do a strabismus surgery. So, thank you very much, Suma. And by the way, see, we have a National Pediatric Ophthalmology and Strabismus Society by the name of SPOSI, Strabismus and Pediatric Ophthalmology Society. So I don't know how many of you, maybe we have more than 1,000 ophthalmologists now who are the members of SPOSI. So are you, how many of you are members of SPOSI? Not sure. But you only half of you, huh? But the hall should have been full, then we could have, had more fun here. But anyway, those who are not members of SPOSI and interested in pediatric ophthalmology and strabismus must become, because this is 7-minute talk, 8-minute talk is not going to help you if you want to learn about strabismus. You have to come to a SPOSI where we have full sessions on this. So, by the way, I am the incoming president of the SPOSI. This year I will be taking over as the president, and we are having a national conference in Nagpur in the first week of December. So, you are welcome to Nagpur. Dr. Shubhangi there, she is the organizing secretary, and it would be very nice of you if you can come and join and learn about that. So with that, we come to the next topic, refractive accommodative esotropia, Jayashri Dora. Oh, I'm sorry, Arnav Singh Saroya, he has a next session, so he is requested, yeah, please come. And he would be speaking on amblyopia, ever-evolving management conundrums. So, yeah, please.
Thank you, sir. Good afternoon, respected faculty. So I'm going to start on my topic, amblyopia, ever-evolving management conundrums. So we've come across a lot of techniques that have been followed over the years, over hundreds of years, of the basic management of amblyopia. We're going to deal a little bit further with the more recent modalities. So amblyopia is the leading cause of monocular visual impairment in children and adults. It is defined as a reduction of best corrected visual acuity that results from abnormal processing of visual images early in life, which cannot be attributed actually to any structural or visual pathway. Most commonly it is unilateral, though it can be bilateral as well, and prevalence is estimated around 1.5 to 2% in various studies, so it's not a very correct number. So traditional amblyopia therapies aim at correcting the refractive error alone, which can improve visual acuity in both refractive as well as strabismic amblyopia. The traditional amblyopia therapies include optical treatment and penalization. Occlusion and penalization of the sound eye has been the gold standard of unilateral amblyopia for a very long time. However, young children with developmental delays, or children with severe amblyopia may not tolerate. If we come to pharmacological manipulation, drugs like atropine have been used. Low-dose atropine of 0.01% has emerged as an effective approach, as highlighted by the atropine in the treatment of myopia studies, ATOM 1 and ATOM 2. Now we come to the emerging amblyopia therapies, which have shown significant progress in the recent years. We start from perceptual learning, video game play, dichoptic video game therapy, oculopad or oculotab, virtual reality, and interactive binocular treatment. Starting from perceptual learning, it's based on the principle that performance of sensory tasks can be improved with consecutive practice. It also involves practicing visually challenging tasks to promote long-lasting vision improvements. The perceptual learning training can be monocular or binocular and requires a rigorous supervised visual experience along with a specific feedback. It can present as an opportunity to treat adults with amblyopia who are thought to be treatment resistant. Coming to video game play, they have an added advantage over the perceptual learning since they present a variety of visual demands and different experiences. Playing action video games has also been associated with release of dopamine, which we do come across a lot of studies that even chocolate increases dopamine. Playing action video games also induces dopamine, which may promote neuroplasticity and therefore promote recovery. Then we come to another modality, that is dichoptic video game therapy, in which a fixing eye and an amblyopic eye view is given different stimuli by presenting essential game elements with high contrast to the amblyopic eye and low to the fellow eye. Thus, binocular viewing is a requirement in these tasks. Another, that is OccluPad or OccluTab, which is a device that processes pictures selectively in the disease eye under open binocular. The only requirement is it requires polarized glasses and a new widescreen technology. The widescreen technology involves stripping polarizing layer of the liquid crystal panel, and it is joined to a strip film. Along with that, there is another, that is interactive binocular treatment, which was developed to treat amblyopia using dichoptic stimuli via virtual reality game. The special software stimulates the amblyopic eye without compromising the fellow eye. The initial pilot studies have promised improvement in the visual acuity, and adult patients also with amblyopia. Use of shutter glasses has also been paired with this technology. Then coming to a very hot topic, which is use of virtual reality in different parts of ophthalmology. Unlike two-dimensional binocular therapy, VR presents a 3D environment in which the child or even a young adult is more visually immersed. This therapeutic approach allows to leverage the sensory motor adaptive capabilities involving the nervous system. While some of these studies do offer promising preliminary results, there is no consistent evidence that amblyopia treatment with any or therapies compared to conventional therapies does help. The fight is still on, and I think with time we will continue to evolve with newer modalities. So concluding it, first and foremost still remains the same. We should give suitable refractive corrections followed by patching for 2 to 6 hours in a day or pharmacological penalization. This can be increased to the length of the adjustment period to maximum per day, and along with educational programs, direct communication with children, their parents, and making sure that the follow-up visits over the years is strictly followed. Thank you.
Thank you, Doctor.
Thank you, sir.
We will discuss at the end because we have a lot of papers. Let's finish with those first. Now, Jayashri Dora, she's here. Refractive accommodative esotropia. You have not. No, then you'll have to wait. Wait a minute. Then yeah, we'll get the next speaker.
So we have Dr. Akansha Raghuvanshi speaking on a brief focus on intermittent exotropia. Ma'am, we'll take you later after this.
Yeah.
Just download it.
Just download it there. Yeah.
Good afternoon, everyone. So I'll be discussing about intermittent exotropias. So intermittent exotropia is a large phoria that is intermittently controlled by fusional convergence. Von Nuden said that 75% of 51 untreated patients in the age group of 5 to 10 years of age, they showed progression over a follow-up period of 3.5 years. But some studies say that if for a longer period we see the follow-up, then some patients, they show improvement also. So there are various phases of exodeviations. Like in phase 1, there is exophoria at distance, orthophoria at near, and these patients are asymptomatic. Then in phase 2, intermittent exotropia is present for distance, orthophoria or exophoria present at near. These patients are symptomatic for distance. Then phase 3, exotropia is there for distance, exophoria or intermittent exotropia at near. Binocular vision is maintained for near in these patients with suppression scotoma at the distance. And in phase 4, exotropia is present at both distance and near, and there is lack of binocularity. So what is the etiology behind intermittent divergent squint? So there can be innervational factors like there is an imbalance in convergence and divergence mechanisms, or there can be some mechanical factors like the position of the orbits or the position of the extraocular muscles. There has been seen a role of defective fusion, and the patients of intermittent exotropias are also seen to be associated with high AC by A ratio. And theory of hemiretinal suppression has seen to be associated, like there is temporal retina suppression in these patients, and there is a role of refractive errors also. Like in high myope patients, they don't need much accommodation. So those patients, they have a tendency, eyes to go out. And in high hypermetropes, due to decreased vision, these patients are not able to accommodate. So obviously, then also these eyes have the tendency to go out. So there are some sensory adaptations in these patients. In tropic phase, most of the patients, they show large suppression of the temporal retina. Anomalous retinal correspondence is seen in the tropic phase, and normal retinal correspondence is seen in phoric phase. Some patients also develop monofixation syndrome, and these patients do not have normal bifoveal fixation, but they have high grade of stereopsis present. Some patients may develop even significant amount of amblyopia, and if there is a late onset of exotropias, that is after 6 to 7 years, when the children, the age of the plasticity has gone. So these patients, they experience diplopia also. So there are two types of classifications which we generally follow in these patients. First is the Burian's classification, which has basic type, divergence excess type, convergence insufficiency type, and simulated or pseudo-divergence excess type. Another classification is the Kushner's classification, in which there is basic type, in which distance deviation is equal to near deviation, that is present in about 37% people. Then if there is a role of tenacious proximal fusion, that is in those patients the distance deviation seems to be more than near deviation, but after 60 minutes or 30 minutes of occlusion, both the deviations become equal, and it is present in about 40% people. And there is like other classification, other groups also, like high AC by A ratio, proximal convergence, people having low AC by A ratio. So these are classified accordingly. So this is the Kushner's classification. There is a role of genetics also in this. So the children of intermittent exotropias, they can have a positive family history. Craniofacial anomalies and neurological defects are also seen to be associated. And maternal smoking during pregnancy and low birth weight are the risk factors for this. So what has been the age of onset in these patients? So Burian and Spivey, they reported that there is 63% of the patients, they present at the age of, their age of onset is less than 5 years of age. And out of those, 35 to 40% patients, they are presenting before second year of life. And female preponderance is more in these patients. The precipitating factors are like when the child is daydreaming, or when the child is tired, or when the child is sick, then it becomes manifest. So how to elicit? In this we can see that there is a divergent squint, and when the patient focuses, so the eyes become orthophoric. So what are the symptoms? There can be transient diplopia, there can be asthenopic symptoms, there can be diplophotophobia. This is seen to be present because when the light is there on the retina, then it dazzles the temporal retina, and the child can experience diplophotophobia. And micropsia is due to the role of high AC by A ratio. So these patients, it is very important to test stereopsis, both near and distant stereopsis. Motor control plays an important role. So there is a revised Newcastle score for this, in that we check for the home control and the office control. In home control, grade 0 is when there is no deviation present at any time. Grade 1 is when it is present in less than 50% of the times fixing that at distance. Grade 2 is when it is fixing more than 50% of the times at distance, and grade 3 is when it is present more than 50% times in both distance and near. And in clinic control, it is for both near and distance. That is, if it immediately realigns after dissociation, it is grade 0. If it realigns after a blink, it is grade 1. If it remains manifested after dissociation, it is grade 2. And if it manifests spontaneously, it is grade 3. So it is very important to measure the angle of deviation. It is done by patch test, which differentiates pseudo divergence excess from true divergence excess, and then we do the +3 diopter. We apply +3 diopter lens to check for if there is any high AC by A ratio present or not. So does conservative management really works? Conservative management, we give it in those patients who have less amount of deviation. Like we can give prisms of up to about 20 prism diopters, and we can prescribe some fusional exercises also. So refractive management is important. We give full myopic corrections, full astigmatic corrections, and in hypermetropes, if they're not corrected, then they can stimulate accommodation and
You'll have
convergence.
to conclude, please, because
Yes,
it's
sir.
already 9 minutes now.
So such patients, the amblyopia is also need to be treated for improving the control also, but this is still controversial whether it improves intermittent divergent squint or not. We can prescribe minus lenses also, but they have to be eventually discontinued. We have to see the progression of intermittent divergent squint. If it is progressing, then we have to go ahead for surgeries. So these patients, there is a controversy whether to operate in early ages or whether to operate on later ages.
Please sum up, please sum up.
Yes, sir. So the goal of the surgery should be to realign the binocularity and basically not to develop amblyopia, and so that the children have their preserved stereopsis also. So there are a lot of controversial issues in this, so we need to treat these patients very wisely. Thank you so much.
Thank you, Vinod. I'll just give you a piece of advice. You should show more about the cases. This is mainly theoretical. See,
Yes.
this is not a PG class or this. Please don't mind. But I would advise you that in the next papers, you should show more practical the cases where you see what type of intermittent and with the excess true divergence, pseudo divergence, or whatever it is. Like that, you should show something on that. Thank you very much.
Okay,
So
thank you.
next we have.
Did you download?
Yeah.
Then please come.
Please come here.
On refractive accommodative isotropia, Dr. Jayashree Dora.
Good afternoon. I'm going to talk on refractive accommodative isotropia. Actually, I came across one case, a 25-year female lady who had isotropia and on examination, her visual acuity was 6/24 and it was not improving with glass. It didn't improve with glass, but fundus was, everything was normal, and she had developed amblyopia. Accommodative isotropia is a condition where excessive effort of accommodation, it results in inward deviation of the eyes. It's caused by uncorrected hypermetropia, and it comprises of about more than 50% of all childhood isotropias. So it can be refractive accommodative isotropia, non-refractive accommodative isotropia, or partially accommodative isotropia. So in refractive accommodative isotropia, mostly the etiology is moderate hypermetropia. Sometimes it can be hereditary. So refractive accommodative esotropia, uncorrected moderate hypermetropia will give rise to retinal image blur. So it the patient will make no effort of accommodation. Thank you. It will give rise to orthotropia with ametropic amblyopia. And if makes effort of accommodation to clear the retinal image, then it will lead to accommodative convergence. So if insufficient fusional divergence is there, then esotropia will develop. Sufficient fusional divergence is there, then esophoria will develop. And low or flat AC by A, then esophoria will develop. So refractive accommodative usually it starts at the age of 6 months to 7 years of age, averaging 2.5 years. And it can be intermittent, then become constant over time, often initiated by trauma or illness, frequently associated with amblyopia, may be associated with diplopia in older children, but later it disappears as a suppression develops. So the mechanism involves 3 factors. One is uncorrected hypermetropia, 2 is accommodative convergence, 3 is poor fusional divergence. So refractive, it can be refractive normo-accommodative esotropia, refractive hyper-accommodative esotropia. So uncorrected hypermetropia, to see clear at distance, they accommodate normal AC by A ratio. Then ESO deviation is same for distance and near fixation, which is within 15 prism diameter. So the hypermetropia is moderate. It responds well to full correction of hypermetropic glasses. And very high hypermetropes may not accommodate even for distance, so may have only bilateral amblyopia. And in addition to esotropia and amblyopia, it may present with asthenopia due to constant accommodative effort. So this is like this, which the esotropia, it improves with full correction. So uncorrected refractive hyperaccommodative esotropia is uncorrected hypermetropia. To see clear at distance, they accommodate, plus convergence is there. So excessive high accommodation by A ratio. So normal AC by ratio is 3 to 5 prism diopter by 1 diopter. Esotropia for near fixation at 33 centimeter is more than 1.5 PD excess of that at distance. So even with full correction of hypermetropia for distance, cycloplegic correction, we'll have a residual esotropia which will need additional near correction as bifocals. Management, refractive accommodative esotropia is hypermetropic correction and surgery. So hyperemic correction, glasses must be worn on a full-time basis. Full correction should be given. With a part-time use of glasses, the child's accommodation is never fully relaxed and the vision is blurred whenever the child is intermittently returns to using the hypermetropic glasses. After initiation of spectral correction, the esotropia will increase when the child is not wearing glasses. So sometimes the parents are confused that with use of the glasses, our esotropia has been increased, squinting has been increased. So, and this should be explained to the parents. And the child should be re-evaluated at 1 or 2 months. And if the esotropia is fully corrected within 8 to 10 prism diopters, that is for near and distance with the full hypermetropic correction, and the patient regains good fusion, and this is consistent with refractive accommodative esotropia, that is fully accommodative esotropia. Absence of asthenopic symptoms also indicates that the success of initial treatment. If esotropia for near persisting after use of glasses as per cycloplegic refraction, consider for bifocal glasses prescription. Still, if esotropia is persisting, then consider for surgery.
Thank you. Thank you, Doctor.
Sir, childhood esotropia must be evaluated timely and properly, and management by prescribing appropriate glasses, unifocal, bifocal, as per diagnosis, and timely re-evaluation should be done to see the effect of treatment initially every 1 to 2 months, later yearly as child attains age of 8 to 9 years.
Yeah, we got it. Thank you very much. See, just one comment for you also. You know, you said treatment is specs and the refractive surgery.
No, so sir, that's wrong. That
So
typing
you
mistake,
you
sir.
should.
Sorry, sir. That's why I told this Squint are not
No,
refractive surgery, sir.
see, you are presenting a paper as a faculty talk at an all India conference, and you should see before, you know, when you are presenting something, what is it correct or not? You see, because it sends a wrong message to the audience. This is a faculty talk, not a free paper.
Yes, sir. No,
Also,
it is,
I'm sorry.
I'm sorry, sir.
No, it doesn't make difference. Sorry to me, but you should always see what you are presenting, you know, before. Thank you. Sorry.
Actually, sir, in our Odisha state, there is a misbelief that in childhood, if some squinting is there, then it is good. It is treated as Lakshmi. So
No, it is in all rural areas, you know, most of the places it
Yes,
is
sir.
there. They think it's a good omen, but your duty is to educate and, you know, convince the what
Yes,
is
our
right.
community
No,
is
we are
very
not talking
important,
about that. Forget
Okay,
about
sir.
it. I'm only said about the refractive surgery which you said. Okay, so please be careful next time. Okay. Next we have Ramia Ticheri, non-strabismic binocular anomalies. Non-strabismic binocular vision anomalies. Okay. Ramia Ticheri, she is here.
Yes.
Yeah, please.
Good afternoon, everyone. At the outset, I would like to thank AIOS for giving me this opportunity. So, my topic is non-strabismic binocular vision anomalies. Why this topic? We know that our visual demand has increased these days. Previously, when we only read. But now, see, looking at this talk, you will be looking at your mobile in between. So, you have to use your accommodation in between. So, coming to my topic, before doing any non-strabismic orthoptic evaluation, you have to correct your refraction and monocular correction as well as binocular balancing. Because binocular balancing, if you have not done, it itself can give rise to accommodative issues. So I will be covering tests of accommodation, tests of convergence, as well as of some anomalies. So we know that your accommodation and convergence is interrelated. So if you have one problem, it can give rise to the issues in the other also. The previous speaker has already told about the AC by A ratio, how your accommodation and convergence is interrelated. So coming to test of accommodation, you have accommodative amplitude and near point of accommodation. That tells you the strength of your accommodation, and the negative relative evidence that tests your relaxing ability of accommodation, and then you have the positive relative evidence that tests your stimulating ability of accommodation. And other than that, you have accommodation facility and monocular MEM retinoscopy that tests the flexibility of your accommodation. So just see how your accommodation amplitude is, near point of accommodation is tested. You explain the patient very well how you are going to do this. So you can do this with a RIF ruler. The patient has to concentrate on N8 or N7 in the near chart, and you bring the target close to the patient, and the first sustained blur the patient sees, that is measured in centimeters. That is your near point of accommodation. And how will you calculate the accommodation amplitude? Whatever you get, 100 divided by that much centimeter. So if you get a 10 centimeter in your near point of accommodation, your amplitude of accommodation will be 10 diopters. And now you have to measure what is the expected for that age. Accommodation amplitude is related to so many factors. The important one is age. So you have to calculate the expected amplitude of accommodation. You have different formulas like Hofstadter formula, that is 15 minus 0.25 into age, and we have an Indian formula from Dr. Jamila Rizwana, 18.5 minus 0.3 into age, and rule of 4. Coming to negative relative accommodance. Here, what you do, you ask the patient to concentrate on the N8 letter, and you will be, here you are testing your relaxing ability. So you have to put plus 0.25 diopter lenses in increments, and until the patient sees a sustained blur. So that you will taken as the NRI value. Similarly, if you have to test your positive relative accommodance, then here you have to do, instead of plus, you have here just stimulating ability. So you have to put minus 0.25 diopters in increments until the patient sees the sustained blur. That is your positive relative accommodance. Coming to the accommodative flippers. So here what you do is, you have to use accommodations flippers. You can either use a plus or minus 1.5 or plus or minus 2 diopter, and you need a rock card which is using the NA target. Then you will flip the accommodation flipper, and the patient has to read clearly. And if you are getting some 10 flips per 1 minute, then you have 5 cycles per minute. 2 flips will be 1 cycle. Coming to MEM retinoscopy, this is done in a well-lit room, and here the patient first reads this distance vision, then you ask the patient to look at your MEM card, and you see how is the refraction. So if normally we have a plus 0.25 to plus 0.75. If it is more than plus 0.75, then you call it as a lag of accommodation, and if it is less than 0.25, then you call it as a lead of accommodation. Now coming to the next part, the second part of my talk, that is the test of convergence. So here you have near point of convergence, negative fusional convergence, positive fusional convergence, and convergence facility. So how will you calculate the near point of convergence? As if you are doing in an NPA, here NPC also you can do either with an RIF ruler, or you can do with a pen light and a green filter. So here you will be moving the target to the patient's nose, and when the patient is not able to fuse, then you record the break point as well as the recovery point. So that will be taken as the near point of convergence. Now negative fusional convergence. Here normal tendency of our eye is to converge. So when you are doing a negative fusional convergence, you have to do it for distance first, then come to near. So here you are testing divergence amplitude. So you have base in prism is placed in front of one eye, and you keep on increasing the prism until the patient sees blur, then break, and then you again come back to the normal place. You will get a recovery point. Similarly, for positive fusion, this has to be done for distance, then for near. Whereas in positive fusional vergence, we will do first for near, then for distance. Same like negative fusional vergence, but here you place the prism base out. Vergence facility, here what you do is, like accommodative flippers, we have vergence flippers, either 12 base out and 3 base in, or 16 base out and 4 base in, and we do it in cycles per minute. How many flips divided by 2 will be your cycles per minute, that much. So these are the normal values. I am not going into the details, that you can find it in any talk. And coming to the anomalies, the accommodation and convergence anomalies give rise to these problems like blurring of vision, double vision, poor concentration and all. So you have accommodation insufficiency, ill-sustained accommodation, infacility, and paralysis and spasm of accommodation. I will be going through the important ones. So in accommodation insufficiency, what happens is the patient is able to see clearly for distance, but after some, when they prolong the reading, everything will become blurred. So here patients have a low accommodative amplitude, and you will get a high NRA but low PRA. Patient is not able to relax accommodation. So fails with the minus lenses in flippers, and MEM lag will be more than 0.75. Sorry, high NRA. And in accommodation infacility means when you read the book, it's everything clear, but when you look at the distance, it's not clear. When you look at a far distance, everything clear, but when you look at the book, it's not clear. So there is infacility for both. So here accommodation amplitude will be normal, but your NRA and PRA will be less, and it fails with the minus and plus lenses. Spasm of accommodation, you will be getting a variable refraction. You have low NRA and high PRA. This is either due to the parasympathetic system overstimulation or poorly functioning sympathetic system. Sometimes in psychogenic factors, cholinergic cues, and secondary to head trauma, all these can lead to accommodative spasm. And paralysis of accommodation, you will get a non-presbyopic patient come with a poor reading. So that can, like Addis people, third nerve palsy, cycloplegic drugs and trauma can give rise to paralysis of accommodation. Coming to the convergence insufficiency that we commonly see, here fatigue after prolonged near work and poor concentration, and patient will be seeing double for near. When you do an orthoptic evaluation, normally there can be an exophoria for basin. But here you will get an exophoria more for near than for distance, and your NPC will be reduced, your PFE, the patient is not able to converge. So positive fusional vergence will be less than 15 diopter, low AC by ratio, NRA will be less than plus 1.5, and difficulty with the plus lenses. In convergence excess also you will get these types of symptoms, but the patient will be getting intermittent esotropia or esophoria.
Yeah, thank you. You'll have to now.
Okay, thank you for the interest of time. I'm stopping here.
Very good coverage. Good. Thank you. Give her a clap. You know, she has done. In 2017 AIOCMT journal, I had a guest review article on accommodative anomalies in children, because nobody believes that there could be an accommodative anomaly in children because their accommodation is flawless. But no, as what she has said, there are at least four types of accommodative anomalies in children, you know. And then I did about three, PG thesis also on that. And it was really true, you know, what Donders had said before 50, 100 years back actually, that, you know, the children having headache and they are not interested in reading and they go to school, and everybody, they keep on running from pillar to post, you know, koi 5.5 zyada kar de, 0.5 refractive, but no, they have an accommodative anomaly. So, you must always consider that if the refractive error is not helping a child, you must do certain accommodative tests, especially accommodative lag and accommodative infacility, what she has said. So, in my book also, my textbook which I published last year, is a full chapter on accommodative anomaly in children. You should go for it because that is what. Now next we have Nahid Akhtar, recent advances in pediatric, pediatric cataract management.
Very good afternoon to the respected chairpersons here and the esteemed audience here. I will be talking about recent advances in pediatric cataract management. As we know that pediatric cataract, it is very different from adults, and it poses lots of problems. And recently we have seen a lot of advancements in the pediatric cataract management in the form of safer anesthesia, newer techniques, newer IOL power calculation formulae, IOL designs, better understanding of neurobiology and genetics, and amblyopia management and adjuvant postoperative care. Coming to the pre-op evaluation, we have now availability of portable slit lamps, portable keratometry, swept source optical OCT, and HRES OCT, which has made our job much easier. The availability of minimally invasive instruments in the form of radiofrequency, diathermy, plasma blades, modern vitrectomy machines have facilitated our CCC, which has to be very round in pediatric population to facilitate IOL implantation. The future holds good for customized OCT, Zepto, and stem cell research. Now the question comes, when to operate these patients? The bilateral cataract patients, they are supposed to be operated from 6 to 8 weeks time. And if it is bilateral, of course, the second eye has to be either operated in the same sitting or after 2 weeks time, within 2 weeks time. Unilateral cataracts are from 4 to 6 weeks of time are to be operated. Now planning for surgery, if the child is around 1 year of age, one should go for lens aspiration, PCC, and limited anterior vitrectomy with secondary IOL implantation. From 18 to 2 years of age, lens aspiration with IOL implantation, PCC, and limited vitrectomy. From 2 years to 5 years, lens aspiration with IOL plus minus PCC. Older than 8 years, lens aspiration and IOL or plus minus PCC, because he can undergo laser later on. Coming to IOL power calculation, the handheld autokeratometers, the availability of ultrasound biometry in the form of immersion and applanation techniques, optical biometry, which are more precise and more error-free, are now available, which have given us more predictive value for IOL calculation. Immersion technique, as we know, is more accurate than applanation technique. The formula which we use for pediatric population is SRK-T and Holiday 2 formula, which have least predictive value. Dahan has given us a little rough estimate for under correction in these patients. If less than 2 years of age, 20% reduction in IOL calculation, and from 2 to 8 years, it is 10%. Recently, we have the studies have given us one more formula in which they have predicted the IOL calculation, which is more fit for emetropia at the age of 15 years. Choice of IOL, we know that it is foldable, hydrophobic, acrylic IOL, which is most suited in pediatric population with square edges, which inhibits lens epithelial cell migration and PCO formation. The hydrophilic lenses with hydrophilic anterior surface and hydrophobic posterior surface are the perfect IOLs in pediatric population. Nowadays, more and more people are also going for toric and multifocals, in which the setting for astigmatism is very, in toric IOLs, we can settle the astigmatism very quickly. And multifocals all can give problem-free post-operatively. Viscoelastics, we have to use high molecular weight OVDs in this population in the form of Helon GV and Helon 5. Tryphan blue dye, it causes capsular stiffening in these patients, which prevents a runaway rhexis. And in the anterior capsule, in the surgical considerations, we have mechanized anterior capsular rhexis, vitreorhexis, radiofrequency diathermy, Fugo plasma blade, which are the recent things which are in femtosecond laser, which has made our job easier. The rhexis, if it is more precise and accurate, our job is mostly done. The availability of foldable template intraocular rings are also available to make our capsular axis much precise. Now one concept is bag in the lens implantation, which many people are following, in which there is anterior and posterior axis is done 4.5 mm, and anterior and posterior capsules, they are put into grooves of the IOL, and it is thought that it prevents migration and proliferation of epithelial cells beyond optic edges. Capsular polishing and capsular optic capture also prevents the most dreaded complications in this pediatric age group, which is PCO and dreaded inflammation. Many of the our microscopes are provided with the rhexis assistant, which can help us do a round rhexis in these patients. Now, post-operative management, as we know that we have, if we can put heparin-coated IOLs in uveitic patients, and along with that, the intra-injection hydrocortisone or dexamethasone is given to prevent post-operative inflammation and phimosis of the capsule later on and PCO formation. And along with that, to prevent end-off, we can give intracameral antibiotics. And cyclopentolate eye drops are recommended 3 times a day in most of the patients. Now our job is half done if we don't give post-operative refractive correction in these patients, and for which nowadays small diameter high plus self-adhesive lenses are available, which can be stuck onto the frame, and child can cooperate, have good compliance with these glasses. Our job is half done if we don't go for amblyopia therapy in these patients, because many patients are reporting late to us, and we should be going for amblyopia therapy in these patients to settle the vision problem. And
ma'am, you can sum up.
Yeah. The artificial intelligence is now taking its role in the pediatric cataract management in the form of pre-op assessment and IOL calculation. And to conclude, the advancement in technology has remarkably improved in surgical outcome. Zepto and HRES OCT will be the future driving technology in these patients. The biggest hurdle remaining is precise IOL calculation in pediatric population. Okay, surgery is only a part of the management process, and the final outcome depends on post-operative follow-up, compliance, early detection, and amblyopia management. Thank you. Thank you.
We have finished our time, but we have a last talk.
So
Just
we were-
last speaker, Dr. Yogesh Shokla. So
we were handed over this session 7 minutes late. So if you have permission, can I have a
so small
my
thing, yeah, he's going to speak on congenital epiphora. So the
Karo
topic.
bhai. Yeah. Okay. So it's a very simple but very important topic, and I told Dr. Namrata that let the people know about it. So now there are certain scientific facts which have to be kept in mind when we deal with epiphora in infants. Number one, tears are secreted by main lacrimal gland and accessory lacrimal glands of Croppa and Wolfram, which are in the conjunctival fornix, in the superior conjunctival fornix, and very few in the lower conjunctival fornix. These lacrimal glands are fully functional by 2 weeks after birth. Accessory lacrimal glands contribute to only 10% of the lacrimal secretion we have. Though the tears begin to show by second day after birth, but they are very scanty. Eyes do not dry with these scanty tears, as the infant eyes remain closed most of the time. In 80% of cases, the lower end of NLD, which is the valve of Fastner, is open on birth. Now, why this natural history is important? A newborn may suffer from toxic, herpes, bacterial or chlamydial conjunctivitis within first 2 weeks of life, if you know that. But the epiphora is very scanty, and therefore focus should be on the disease rather than the watering. After this period, any epiphora along with any other condition which a concomitant applies should be suspected for NLD block also. Now, what you have to look for? Once you have confirmed that there is this is congenital epiphora is due to some congenital problem of the drainage system, what you have to look for is number one is the not only in NLD, you have to look for the congenital atresia of the puncta or canaliculi, epiblepharon, entropion, diastichiasis, structural craniofacial abnormalities, Down syndrome, non-membranous NLD obstruction, that is the cartilaginous, and the quality of these tears should be also looked into. Whether it is aqueous, if it is aqueous, intermittent discharge shows blockage of NLD due to nasal mucous membrane, swelling in URI, so that is important. If it is intermittent, watery, and with nasal problems, it should be not considered as NLD block, but an URI of the nasal one. While mucopurulent discharge goes in favor of NLDO, that is the norm. Now, once we have confirmed that it is a congenital nasolacrimal obstruction, we have to look into that direction, and that is it affects about 20% of newborns. You should have to keep in mind. Spontaneous resolution occurs in 90% of infants within first 4 to 6 weeks of age. Most studies say persistent unresolved epiphora remains in 5 to 6% cases only, which may or may not resolve spontaneously by 6 months or maximum 1 year of life. Before embarking on invasive management procedures, diet disappearance test is a good way of confirming NLDO. You know what is a diet disappearance test? You put a dye in the conjunctival sac and you wait for 5 minutes, okay? And if it doesn't disappear from the congenital sac or doesn't appear in the nose, which is difficult to know, but if it doesn't disappear, that means it is a congenital anal tube. Now, once it has been confirmed that it is congenital NLDO, then you have to go for the management. And this management includes lacrimal sac massage, which is a Krigler method, almost 30 years, 3 decades before. But you must, as a pediatric ophthalmologist or even a general ophthalmologist, you must know how to do a lacrimal sac massage. In most of the conditions, they go to a pediatrician, and the pediatrician, they advises them the wrong way. This is not the way. We don't have the time for that. I cannot tell you what is the exact method, but you must learn the exact method of lacrimal sac massage. Then LLD probing, balloon parting, and we have the other ways. Now, what is important is, if epiphora does not resolve by 6 months of age, then intervention is needed. Probing remains the first line of management, and studies from various dedicated centers around the world have shown the following. Now, this is important because when do you want to probe is a big controversy. Now, the success rate of probing at 6 months to 12 months is 92%, 24 months is 85% almost, 36 months is 80%, 48 months is 70%, and after 60 months, that is 5 years, it is only less than half. So probing can be repeated 2 to 3 times also, but not more than that. It is a blind procedure, skill is needed, and the tactic has to be mastered. Now, the crux of the problem is that there is a controversy regarding the timing of probing. This is very important, and all pediatric ophthalmologists, because it comes under the domain of pediatric ophthalmology. No general ophthalmologist should try to do a probing, because it has to be learned that it is a skillful process. Don't do it, otherwise we are not trained for it. Now, should probing be done as early as 4 to 6 months, which is normally many people do or think of, or should we wait for 12 months of age, which some studies have proclaimed is the last limit of spontaneous resolution? Now, the answer is as controversial as the question. Most ophthalmologists like me prefer to do it between 6 months to 1 year, except in congenital dacrocele where it is needed. Now, there are ways why the probing. Now, this is a procedure which I have developed. You do the, this is the Bowman's probe, you do the probing, and this is how the probing goes. You must know the direction. For a pediatric ophthalmologist, you must know the direction of the probe, backwards, downwards, and laterally. That is very important. And then this is a fluorescent dye which I inject, and the anesthetist puts a nasogastric tube in the nose, and you see, that's another important is the amount of the saline which you are giving, because the child is under anesthesia. Okay, you should not do too much of not more than 0.5 or 0.7. You go that it might go into the lungs. So this is very important. Not 2 millimeter or 5 millimeters. Now I have just it is 1. It's 1. I have just given 0.5 in the nasal cavity, and you can see it has come in the nasogastric tube. That green color has come in the nasogastric tube. So this is what I routinely do. Now, it is available in the stores here also. We don't have to use the Bowman's probe. This is a probe which is hollow, and it is a hollow at this end. See, it is hollow here. It is a hollow tube, it is not a Bowman's probe. It is a hollow tube, and it has indications 5, 10, and 20 millimeters. You do not go beyond this into the nose. Okay, otherwise you'll make a false passage. This is basically about 5 to 8 millimeters, 10 millimeters for the lacrimal sac, and another 8 millimeters for the NLT. And you don't have to take it out again and again. This is a syringe which is attached at one end with this, and at the same time, once you have done the probing, you inject this fluorescent dye, and it comes into the nasogastric tube. This is another thing. Thank you very much.
Thank you, sir, for an excellent presentation. I think we close the session because I think the next session has to start.
I'll just stand because I have to close the session and you know, normally by 6 months, the NLD length is already just only thing is that it is cartilaginous, it does not have the bone, that's a different thing. But we always have 8 millimeters of the canaliculus, 8 millimeters of the lacrimal sac, and about 8 millimeters of the NLD. So normally there's only a difference of 3 or 4 millimeters after 1 year. So, you know, by and large, it serves the purpose. But what is important is that you have to do it very meticulously. You must note it, because I have seen many, when I was teaching my residents, just to push the probe like that. No. And this another thing, I have, there are 2-3 theses of it I have done from my residents, how to, this fluorescent dye method is also which I have devised, and a lot of people are doing it. The only thing is that you must know the amount of fluid which you are injecting inside, because it is under GA and the child can aspirate. So that is very important. Not more than 0.5 ml to 0.7 is enough to come into the gastric tube. And the other thing is, you must know the direction. That is very important. The direction of the probe which you are doing for the NLD opening. And one last thing, if you should not have any noise, because when I do this thing, I tell everybody to keep shut in the OT. You can hear the pop. When the valve of Hassner mucous membrane is pierced, you can hear a very small faint sound. If you can't hear the sound, you can feel, the loss of resistance. As you are going, and go very slowly, gradually, and that's why the direction, the markings are important. Don't go beyond the third marking. And as you are reaching the third marking, be very gentle, and you can see the disappearance of the resistance. That is what it is. Thank you very much.